Good morning, everyone, and welcome to the Parkinson Association of Greater Daytona Beach's interactive online webinar program, You, Me, and PD. I'm Vince Kinsler, the Executive Director and the President of the Parkinson Association of Greater Daytona Beach. Our guest today is Associate Professor of Neurology, the Associate Division Chief of Movement Disorders, and Director of Neurology Clinical Trials with the Center for Movement Disorders and Neurorestoration at the University of Florida in Gainesville. He has traveled a long way to be here with us today and to present his program, Management of PD Motor Symptoms, Emergent Treatment Strategies, and Unmet Needs. Please join me in welcoming Dr. Adolfo Ramirez Zamora.
Thank you. Thank you so much, Vince, and thank you so much for the invitation. It's always a pleasure to be able to speak to the audience and then just cover a couple of new things that are happening in Parkinson's. My goal for today's presentation is to talk about some of the most recently approved drugs for the management of Parkinson's disease. I think the audience would be interested in learning about some of these new medications and also cover what's in the pipeline. And I'm trying to keep the presentation focus on management of motor symptoms, but I may talk briefly about new strategies for management of non-motor symptoms, because as we all know, the non-motor symptoms have a huge impact in patients' quality of life as well. And I'll go along and save some time for questions as well. I hope that we have a lot of questions about some of the topics today, but thank you, Elaine, and the people from Boston for really helping and sponsoring this event. Let's just get started. As you know, Parkinson's disease is a progressive disease that is characterized by motor symptoms, including bradykinesia, rigidity, and problems with posture and tremors. And what we know that causes the symptoms of Parkinson's disease is the lack of dopamine or the damage to dopamine neurons in the midbrain. As we learn more and more about the mechanisms behind Parkinson's disease, a lot of new research is being conducted in that area of a very interesting area of research. We now know that Parkinson's probably starts in our gut. And it seems like there's an important relationship between our gut health with our brain health. One of the proposed mechanisms of Parkinson's disease is that if we have the right genetic predisposition, what may be happening is that may, when an environmental factor changes anything in our body, that predisposition may trigger the process of injury to the neurons and Parkinson's disease. And one of the most currently investigated theories is that if maybe that change, that environmental factor has something to do with an exposure to a virus or something in our diet that changes the bacteria in our gut. And from there, those changes may induce inflammation at the level of the small bowel and producing this abnormal accumulation of proteins in the small bowel that eventually reach the brain through the nerves. So it is possible that if we can untangle those very complex associations, we may be able to have an impact in the progression of Parkinson's disease if we change some of the strategies at the level of the stomach, maybe changing the bacteria in our gut, reducing the inflammation in our gut, because we know that it's very likely that most of the symptoms start or the changes that we found in the brain later on may start at the gastrointestinal tract. And I'll talk a little bit more about what are those strategies, how those strategies are looking as potential trials. Parkinson's is the second most common neurodegenerative disease worldwide, and in the next 20 years is going to be the most common condition affecting people in the US, neurodegenerative condition. It's estimated that the numbers of people with Parkinson's disease are going to continue to increase. So it's critical for us to identify not only better treatments to manage the symptoms of the disease, but also hopefully finding ways to slow down disease progression. As I mentioned before, non-motor symptoms are now recognized as part of the disease, and we know that they can cause significant disability associated with the disease, including problems with the autonomic nervous system, causing constipation, low blood pressure, psychiatric and sleep problems, and even pain, just to name a few. For the longest time, we didn't think that pain was a strong symptom in Parkinson's disease, and now we clearly recognize that pain is common and it can present in many different ways. Today's presentation, I'm going to focus specifically in the management of the motor symptoms. One of the things that we are really good at is to treat some of the Parkinson's symptoms early in the disease. So the use of medications that we have available are very good at reducing tremors, stiffness, slowness of movement, changes in posture, and also helping with the gait. What happens over time is that the efficacy of these medications seems to be reduced by the duration of the effect. So despite the half-life of levodopa being exactly the same, what happens is that those dopamine neurons in the brain are having, as time goes by, they have a harder time using levodopa. Levodopa is not dopamine. Levodopa is the pre-drug of dopamine. So the brain has to use levodopa and convert that into dopamine. And the way that the neurons can do that changes over time, making the response to the medication less and less consistent. And as anyone with Parkinson's knows, the only predictable thing about Parkinson's disease is that it's unpredictable as time goes by. It becomes very difficult to know what's going to be the response after you take your medications, how long is it going to last, and the type of the response. Sometimes the response is complete and people take their pills and they feel really, really good after an hour. Sometimes that response is delayed. It may take about an hour and a half to take effect. Sometimes the response doesn't last as long, or the response may be incomplete. And that's something that we term motor fluctuations. There's a wearing off of the efficacy of the medications at the end of the dose. And that's a very common problem in Parkinson's disease. If we look at statistical data, it seems like about 50% of patients have some motor fluctuations, or they report wearing off within the 5 years of the disease. Another common motor complication of Parkinson's is the presence of dyskinesia, these excessive, involuntary, fidgety, restless, dancing, grimacing movements that patients may experience after they take their pills. It's also estimated that about 60% of patients have, at 5 years, have some form of dyskinesia. The combination of wearing off, unpredictable responses to the medications, and dyskinesia when the medications are working, they pose a challenge for the providers because we have to then figure out different strategies to try to minimize some of these concerns and keeping these ups and downs throughout the day to a minimum. One of the initial strategies to be able to do that is to be consistent with the medication intake. So you have to take the medications on time. So that would allow us to make adjustments on that schedule to try to determine where in that specific schedule we need to make sure that the levels of dopamine are a little bit higher. Everyone is different, and the need for levodopa and other medications is different. It depends on a variety of factors that go from impairment in quality of life, specific symptoms, disease duration, etc. But we know that there are certain factors that tend to that are related to these motor complications, like erratic gastric emptying. That's why we, in later stages of the disease, we suggest to take medications with a little bit of food to enhance that the emptying in the stomach. There could be an interference that is more noticeable with protein and the medications, and also there's this competition between amino acids and levodopa to be transported across the blood-brain barrier could be part of the reasons why these fluctuations occur. There are several risk factors for motor fluctuations and these motor complications. And one thing that I would like to emphasize in today is that the idea that levodopa is that the starting taking levodopa is going to increase your risk of motor fluctuations is obsolete. We used to think that that was the case. We used to think that if you delay the introduction of levodopa for management of Parkinson's disease, that will really prevent the development of some of these complications, these unpredictable motor responses that I already talked about. But it seems like that's not the case. It seems like what really dictates who's going to be a higher risk of having these complications are other factors. Like it's not about the use of levodopa, but it may be related to high doses of levodopa needed to manage the symptoms of Parkinson's disease. If you are younger at the age of onset, if you are thin, if you're a female, if you have significant non-motor symptoms, all those appear to be risk factors for development of these motor fluctuations. A couple of studies have been published. The early studies, that KYNMOBIT trial compared the risk of motor fluctuations in patients that were taking a dopamine agonist called Mirapex versus levodopa. And it seemed early on that if you were using other medications like dopamine agonists, your risk of motor fluctuations would be less. But in most recent trials, including the LEAP trial that was conducted in patients with early Parkinson's disease, and they were followed for several years, it seems like at the end, the use of levodopa does not predict the development of these fluctuations. There are a few other studies that have been published since then, and I think the message that I'm trying to convey is that levodopa has to be used when needed. The doctor, your clinician, should be able to gather the right information to decide what are the best medications that you need to take. And it is important because if you have to be able to identify the impairments on quality of life to make those decisions. Because early in the disease, you want to try to manage the symptoms. We have very good treatments for management of the motor symptoms of Parkinson's disease. So we really want to emphasize treatment early on when we can capture those symptoms the best we can and really have a powerful impact in quality of life. But don't worry, if the problem is that you are over-medicated, well, luckily we have drugs that can help with that. Yeah, it's a little funny cartoon about it. I think that once you identify that medications could also induce side effects, judicious use of medications in Parkinson's may be indicated. At times, in Parkinson's disease, it's better to take low doses of 2 medications as opposed to take higher doses of 1 medication. And every patient is different, but you have to decide based on the response and the side effects related to that medication, which is the best combination of medications for a specific patient. What I would like to concentrate over the next few minutes is to talk about some of the newly approved drugs for management of these motor symptoms in Parkinson's disease. Over the past 3 years or so, we have seen significant change on the available drugs for the management of acute off periods. And when I say off period, an off episode refers to the times during the day when someone with Parkinson's disease feels that the symptoms are not adequately treated. In other words, when your Parkinson's symptoms are prominent, that's what you call an off episode. And once you take your medications and the medications kicked in, and then they are working properly, and you feel that you can move, that the tremor is gone, that the stiffness is gone, that's what we call an on period, right? And when you have motor fluctuations, what happens is that you fluctuate between periods of being on and being off. You take your pills, you're on, your symptoms are better, but then the efficacy doesn't last, and then you go back into an off period. One of the strategies that is now available is that we have drugs that can be much more, that could have an onset of action much faster than regular pills. As I said before, as the disease progresses with Parkinson's, the response to taking pills by mouth may be impaired, and at times it may take longer for those medications to have a full effect. If you're having problems with the medications lasting long enough, and you take a pill, and the pill takes an hour or 2 to kick in, well, that means that you're gonna be in an off episode for about 2 or 3 hours. So that's a little too long. So for a while, we have all tried to find better ways to treat those episodes. And we do have some treatments available. We have had the injectable apomorphine, subcutaneous apomorphine for quite some time, which is a very powerful drug to manage the symptoms of Parkinson's disease. Although it has a name of that sounds like a narcotic, it has nothing to do with a narcotic, it has no effect in pain. It was named apomorphine because at the time that it was discovered, it was used to induce vomit. So it will make people very nauseous, and the molecule looked very similar to morphine, although it's a dopamine drug. And we have had this medication for quite some time. That's an injectable formulation. You have to take some nausea medication to avoid that side effect. But then you can inject yourself, and then you have to figure out the right dose. But it hasn't been as practical to really get the pen, adjust it, and inject yourself. So a couple of other strategies are now available. And one of them is this medication called Inbrija. So Inbrija is a dry powder formulation that has been approved for a few years. And it delivers levodopa using an oral route, using a breath inhaler. So what you do is that you open these pills that have a powder levodopa, you crack those pills, you put them in an inhaler, and then you inhale that powder through your mouth. And what this allows is that instead of having to go through the stomach and the gut to absorb the medication, you're taking advantage of the very large area of absorption that happens in the lungs. So the powders will go to the lung, it will be absorbed immediately or very quickly. And what we have seen in randomized studies is that you can see a positive effect on the Parkinson's symptoms within 10, 15 minutes with a maximal response about 30 minutes after taking that dose. The drug has been approved for a couple of years, showing that at 84 milligrams, there was evidence of onset of effect about 10 minutes afterwards. And you could have a clear improvement on the Parkinson's symptoms with a duration lasting about 90 minutes. So the advantage of the medication is that it's quick, and the disadvantage is that it doesn't last too long. Very similar to the injectable apomorphine. Very effective, they start working really quick, but they just don't last too long. The main side effects with this medication have been consistently respiratory issues, particularly cough. So that was the most common side effect noted on the clinical trials. And as you can imagine, inhaling a powder into your lungs can make you cough, and it could be uncomfortable at times. The dyskinesia may occur in certain patients as well. You need to take this medication as an add-on therapy. You need to be taking levodopa to prevent the nausea caused by levodopa. The inhaler only has levodopa. It doesn't have carbidopa, which is the part of the pill that helps to prevent nausea. But in somebody that has occasional episodes of sudden worsening of their Parkinson's symptoms, or slow but relatively consistent worsening of the symptoms later on the day that you want to treat quickly, Inbrija, this inhaler, could be a very good alternative. Another recently approved drug, and this one is brand new, it was just approved, I would say, it has been approved for some time, but available in the US only very, very recently. It's a medication that helps to extend the duration of levodopa. One of the strategies that we have, if you think about these ups and downs when your medications kick in and then we're off, they kick in and then we're off. Well, one of the strategies, instead of taking more levodopa, how about if we block the enzyme that breaks down levodopa? So what that would do is that then levodopa will stay in our system a little bit longer and extend the duration of the effect. There are a couple of drugs that work on that way available. One of them is entacapone. Entacapone has been around for quite some time, and it's a drug that can extend the duration of levodopa for about an hour to an hour and a half duration of effect. But entacapone you have to take every time you take levodopa. It's very short acting. There's another drug called tolcapone that is not commonly used, is not very frequently used. It's a very powerful drug. It extends the duration of levodopa for about 2.5 to almost 3 hours in some cases. But It carries the risk of having liver injury, and for that reason, you have to monitor liver enzymes very closely. So it's not one of the top options, at least in most practices, when we have some other things available that we could use. Uh, so in an attempt to try to find a happy medium in between these two drugs, this drug has been developed called opicapone, and they have been a couple of randomized trials that looked at the efficacy of this medication. This is within the class that is called a COMT inhibitor. So it blocks one of the enzymes that breaks down levodopa. And it appears that in large studies, this medication was able to reduce the off time in patients with Parkinson's disease for about an hour and 20 minutes compared to placebo, to the sugar pill. And then it was also shown to increase adequate function on time without causing significant or troublesome dyskinesia. It's a once a day medication. The safety profile, the side effect profile, seems to be a little bit better than regular entacapone. The most common side effect of entacapone, other than change the color of the urine, is that it can cause some diarrhea. And opicapone appears to be less of a, diarrhea seems to be less of a concern with this new medication. Um, it has been approved I believe there are 2 doses that are going to be available, and maybe an option to manage these episodes of losing the efficacy or benefit in between doses. Another one recently approved drug, it was approved about a year ago. It's a new kind of medication for Parkinson's. What drives the symptoms in Parkinson's disease is the lack of dopamine in the brain. The cause of that is that you need dopamine to be able to enable the normal connections and rhythms in different parts of our brain. When dopamine is not available, the frequency that the brain communicates between neurons changes, and that change prevents the brain to select adequate movement or to move with the speed that we want. And as part of that dynamic, there are different connections between different parts of the brain that are really important to scale the movement and to dictate the speed of the movement. And one of those requires the use of adenosine. When we manipulate that neurotransmitter, these adenosine A2 receptors, what we can do is to reduce the brakes on the brain. If you think about it, the best way for the brain to control movement is to put a stop to excessive movement. So if you have a loop that it's always going and you're trying to move, you may be able to fine tune the movement, slowing down the movements when you need to. So in Parkinson's disease, that brake seems to be excessive. So all the movements are difficult, all the movements are slow because the brakes are on all the time. This medication, istradafilin, it's quite unique because it works on a different neurotransmitter. It's not a dopamine medication, but it seems to help to reduce, to take the brake off the pedal, to take the foot off the pedal, to reduce the brake that the brain is imposing and help to facilitate the movement. This drug has been extensively studied in Europe. There have been multiple studies, up to 5 studies done in Europe and in Asia as well. It has been approved in Japan for a few years. And the effect of the medication is very similar to the previous drugs, to the previous drug that I mentioned. It's about an hour to an hour and 10 minutes of benefit. A very recent study done here in the US, it was a large, very large 12-week study. Multiple centers were part of it. And there were different doses of the medication were tested against placebo. And they overall, they have shown that there's a reduction of the off time compared to the placebo or the sugar pill. And that reduction seems to be about an hour and 10 minutes. The most common side effects were excessive movements like dyskinesia, some dizziness, fatigue. There were very few. It was different. It was just different from the dopamine medications that we're used to. So this drug could potentially be, it could be uniquely prescribed in patients that are having trouble tolerating medications with dopamine. So if the problem is that you're prone to have side effects related to dopamine levels, well, maybe using a medication that is non-dopaminergic, that is not going to affect dopamine, may be the next step. The 2 medications are now available as well for the management of dyskinesia. There's one that has approval for dyskinesia. The first one the first drug that got approved for the management of dyskinesia. They're both amantadine, an old drug that has been around for quite some time. Amantadine was discovered as a Parkinson's medications when people, it's an antiviral medication, so it was commonly used to treat the flu. And in I believe in the 70s, people were taking amantadine to prevent, just to manage the flu-like symptoms or for flu prevention. And people with Parkinson's disease were taking amantadine and they noted that their symptoms were better. So amantadine became an available treatment for Parkinson's disease. It has a variety of different effects on the brain, including an effect on dopamine. It has an effect on other receptors in the brain as well. So we have been using amantadine for management of Parkinson's for quite some time. We learned that amantadine could be particularly helpful in patients that have excessive movement, these fidgety, restless, dyskinesia movements. Amantadine could be amazing in suppressing some of them. There's a limiting dose that you can use. The more you take, the higher risk of having side effects, particularly confusion, hallucinations, skin changes, and so on. So although the drug is very, very good, not all patients can tolerate higher doses. In an attempt to try to bypass that problem, a new formulation of amantadine was developed, an extended release amantadine that is now branded as Gocovri. Gocovri is the same medication, but it's delivered differently. It's a slow release of the medication over long periods of time. So what that allows is a more steady levels in the blood, relatively higher levels compared to regular amantadine, and you can take the medication for a 24-hour period. It's a 24-hour pill. You're supposed to take the medication later on the day because it takes about 7 hours to peak. So you take it at night or at dinner, and then 7-8 hours later, when you're gonna need it the most for management of the dyskinesia, the levels are a little higher. 2 randomized clinical trials, large randomized clinical trials were completed in the past few years that show that the drug is highly effective in reducing troublesome dyskinesia for about almost 3 hours, 3 hours reduction of troublesome dyskinesia during the day compared to the placebo, but also the drug showed efficacy in reducing off time. So when people noted that the medications were not lasting in between doses, that was also improved with the use of this medication. There's another amantadine extended release formulation that was approved for the management of Parkinson's disease and dyskinesia based on how this drug was available compared to regular and extended release and immediate release amantadine. So no studies were done with Osmolex ER, that's the name of this medication, but the profile is very similar. It's the same drug, but this one is delivered, the capsule has a special system that allows very slow delivery of the medication over long periods of time. Another very recently approved drug is this one called KYNMOBIT. It's an apomorphine sublingual film. I mentioned earlier that we have this injectable product that it's apomorphine, that's very effective in reducing the symptoms of Parkinson's disease, but you have to do it through an injection. So if the drug works, it's highly effective. How about if we try to get it into the system a little bit differently? So the two common formulations, 2 common preparations have been tested. One is using a sublingual film, kind of like the Listerine breath films that you put under your tongue. And another one that is an infusion, or it's more like an inhaler. So intranasal apomorphine is currently being studied. It hasn't been approved, but sublingual has. So the studies were done 2 or 3 years ago, and different doses have been tested. And the drug seems to be quite effective in reducing the symptoms of Parkinson's disease. It takes about 10 minutes for the medication to start, and the maximum benefit is about 20 minutes after the dose, and the duration of the effect is about 90 minutes. So again, this is a very useful medication for somebody that has sudden worsening of their symptoms, or the symptoms are not lasting, or the symptoms are coming back before the next dose, and you want reliable, consistent improvement of the symptoms of Parkinson's disease, much easier route of administration. The key with this drug is that there is going to be available in a variety of different doses. It's going to be on 10, 15, 20, 25, 30 milligrams. Everyone will respond differently to this medication. So you need to figure out how much you need. And we're going to be what we're going to have to do as clinicians is that we're going to have to give at least the first dose in clinic to make sure that you respond okay, that the most common side effect or concern taking the first dose of the medication is that your blood pressure may drop too much and you can have like dizziness. But if you tolerate that well, then you can continue to increase the dose until you find the dose that is the most effective and reducing the symptoms of Parkinson's quickly uh, and without the side effects. So it's going to take a little bit of titration to figure out what's the dose that works best. But again, the medication kicks in fairly quickly and it appears to last for at least 90 minutes. The most common side effects noted on the clinical trials were nausea, a little bit of somnolence and dizziness, which is very common. And also people reported some dry mouth and discomfort around the mouth. This was not very common. It was about less than 10% of all the patients in the study. And surprisingly, the medication did not cause confusion, hallucinations, or any other side effects that sometimes we worry with this kind of medication, this dopamine agonist. Another line of really interesting research for potentially managing these ups and downs with Parkinson's disease, these fluctuations, is the use of subcutaneous levodopa therapies. If you have ever seen an insulin pump, what you do with an insulin pump is that you put insulin in a container, something like this, and then you attach that insulin or you deliver the insulin using two small needles under the skin. This is very different of the currently approved treatment called duopa, where you put a PEG tube. So you have to have an endoscopy, and then you put a medication port that it's done the same way that you put a feeding tube. It's not a feeding tube, it's a medication port, but it's done very similarly. And then you attach a pump that has levodopa and delivers levodopa directly into the small bowel. This is different. This is a small amount of levodopa that's going to be delivered subcutaneously. So no tubing, there's none of that. You're going to do a small needle under the skin and allow the infusion to deliver levodopa. Levodopa is going to be absorbed under the skin. So all these issues about fighting with proteins in the gut or inconsistent gastric emptying, all of that, you can bypass all of that using this very small formulation and this small patch device that I'm showing here. If you think about it, the amount of levodopa that you would need if you're taking 20 tablets during the day, it will be hard for this pump to replace all that levodopa with a subcutaneous route. You will need a lot of fluid and it may not be practical. So the pump, as currently being investigated, it allows for a certain amount of levodopa delivered during the day. There are two companies that are currently conducting phase 2 or phase 3 trials. One is Neuroderm, the other one is AbbVie. Both products are looking at measuring the efficacy of this therapy, but it's exciting. It's a very exciting development because it's minimally invasive. The most common side effects were irritation around the area of the injection, but it's very easy to stop. Like all you have to do is pull the needles and that's about it. And it can supplement levodopa and it can increase the level of levodopa and dopamine on the background without having to rely on consistent absorption in the stomach, which appears to be a big problem in more advanced stages of Parkinson's disease. So more to come. The two trials are available at UF. So if this is something that you would be interested, definitely please reach out to us. We think that people that have the ideal candidates to participate in something like this would be people that have 2 or 3 hours of poor control of their Parkinson's symptoms throughout the day, that are taking medications very frequently. And what we're trying to do is use the infusion to smooth out those ups and downs that patients may have. This would be potentially an intervention that it can be considered before before the advanced therapies like duopa or deep brain stimulation. This is kind of how it looks. Also, I want to mention that in the area of neuromodulation and deep brain stimulation, there has been a remarkable, incredible change over the past few years. New technologies are becoming available that provide now different ways to stimulate the brain. Uh, Vince was talking just at the beginning of the presentation about an upcoming webinar to discuss one of the newer devices that are now actually sensing the brain activity and using that activity, that a specific signature of the brain as a potential marker to dictate treatment. But there are so many new things happening in the field of deep brain stimulation that we're hope that it's going to translate into better treatments for our patients. There are better batteries, there's new leads, there are directional leads that allow us to shift the stimulation away from areas of side effects and then just concentrate the stimulation in the areas of benefit. We have technology now that allow us to use different pulses. So we're investigating uh, new parameters that may be better to help with certain symptoms compared to others. So the field of neuromodulation continues to change and provides really, really important and new technology. I think that we are starting to see Parkinson's disease in a very similar way that the epileptologists see patients with epilepsy. We can now recognize those changes in the brain that are related to specific symptoms of Parkinson's. And the new technologies are looking at developing closed loop systems that react to that abnormal brain activity. So we can now identify, okay, there's this electrical change in the brain that tells me, okay, when this happens, patients have more tremor, slowness, and stiffness. And when you're moving, that electrical signature is gone when the symptoms are better. And then if you have too much movement, like dyskinesia, another signal is now identified in the brain. So we're getting close to having a device that can sense when things are happening and then deliver stimulation depending on the state. So that would be in the future. We hope that we can actually modulate symptoms that come occasionally and then adjust the stimulation based on the needs during the day, as opposed to selecting the amount of stimulation and you stay on that all the time. We're starting to learn what happens during sleep, what are the changes related to deep brain stimulation during sleep, and how can we use that to really improve the technology and improve the treatment of Parkinson's patients. Another therapy that I would like to mention is that I talked already about the apomorphine injectable Apokyn. We have had that for some time. I mentioned that there's sublingual apomorphine, KYNMOBIT, this new medication that's just approved. And there's a theme, right? Apomorphine appears to be a very effective drug to treat the symptoms of Parkinson's disease. It just that doesn't last too long. The benefit is good for an hour and a half. So how about if we can deliver apomorphine continuously throughout the day, and then we prevent some of those ups and downs? Well, this therapy has been around for quite a few years in Europe, and it's undergoing an open label phase 3 study here in the US. I think the study has been completed and we're just waiting for the results of that. And the idea is very similar to an insulin pump, but instead of using levodopa or the levodopa pump, instead of using levodopa, you would use a different medication. In this case, apomorphine, which is a powerful drug. The problem, some of the side effects with dopamine agonists like apomorphine is that at higher doses, you may experience confusion, somnolence, nausea, and low blood pressure. So there may be a limit of how much you can use, but the experience from Europe has shown that these infusions could be very, very effective in reducing the symptoms of Parkinson's disease, and maybe particularly helpful in people that have pain, that have constipation, and also in patients that have some hallucinations, because this drug is metabolized to a compound that has very similar chemical characteristics to one of the medications that we use commonly for patients with for hallucinations. It's still early to tell. The effect of dyskinesia is a little more variable, and we don't know exactly what are the non-motor symptoms that can benefit the most with this specific infusion. And I mentioned already that there could be some side effects and some tolerability issues. A couple other things that I would like to mention, and then I'll stop so we can have some questions, is there are two new drugs, the dopamine. There are a couple of dopamine agonists that are being tested in phase 2 or phase 3 for management of wearing off. The first one is Amantadine, which activates dopamine 1 receptors. Dopamine 1 receptors, all the drugs that we have available in the market do not activate dopamine 1. There are different kinds of receptors in the brain, from dopamine 1, 2, 3, 4, and 5. There's a different effect depending on the receptor that you're activating. Dopamine 1 receptors appear to be particularly important for movement. So it seems like the drug is well tolerated and is effective in reducing the wearing off in between doses. So it's in phase 3 trials. I think the trials are just ongoing. So we will probably have the results by next year or two. Another drug that is currently in phase 3, it's a new extended release form of levodopa. If you heard of Rytary? Rytary is an extended release form of levodopa. It's a combination of immediate release and extended release levodopa, but it's delivered through these micro granules that attach to the small bowel and allow a more consistent absorption over hours, increasing the duration of effect for at least an hour to 2 hours. The new, this IPX203, it's a new, very similar compound that appears to increase the duration of effect up to 3 or 4 hours, which means that if you're taking medications maybe 5 times a day or 4 times a day, you may be able to reduce it to 2 or 3 times a day with similar efficacy. So phase 3 studies are currently done. Phase 3 studies mean that they are being tested in large population, and they are typically compared with a placebo or other drug to see the real efficacy. The CVN 424, it's another dopamine receptor agonist that is in phase 2, a little early phase. It's a phase that's looking at safety. Can people with Parkinson's tolerate this? And also at the same time, looking for a signal of potential benefit. Again, a dopamine agonist that may be quite helpful to help with the Parkinson's symptoms. The newer dopamine agonists, what they're looking at is not only efficacy. They want to see if they're better tolerated compared to the current dopamine agonists that we have on the market. A few gene therapies are being studied as well. A variety of different companies are looking at using a virus to deliver the genes in the brain that produce dopamine, with the idea that if you can get these dopamine neurons to, you give them the right machinery to produce more levodopa, they can produce dopamine on their own. And the early studies have shown some encouraging results. When patients have significant improvement of their motor symptoms, there's at least 3 companies looking at conducting phase 2 or phase 3 trials, some of them starting next year. There's also enzyme replacement studies for patients that have genetically defined Parkinson's disease, people that have these mutation, GBA mutation, which is a mutation that reduces the amount of these lipid in our bloods. It's a risk factor for Parkinson's disease. So enzyme replacement therapies are looking at a specific group of people, specific patients with Parkinson's disease that have this mutation and low levels of the enzyme to see if you replace the enzyme, can you slow down Parkinson's disease progression? So there's at least 3 companies looking at that, and they're doing phase 2 studies. The goal is to develop therapies that may not only help with the symptoms of Parkinson's, but also slow down the disease progression. And there are a variety of neuroprotective trials being conducted right now. There's a trial of an exercise. I'm sorry, this is a typo. There's another drug called exenatide. That's a medication used for diabetes that has shown to be potentially effective in reducing Parkinson's disease progression, as well as medications that are targeting this abnormal protein that appears to be the leading source of injury to the dopamine neurons in the brain. So this abundant component of these changes, pathological changes in the brain of patients with Parkinson's disease. So the theory is that if we can slow down the accumulation and the abnormal clumping of this protein, we can protect the neurons and the dopamine neurons so they can function better. So all these studies are in phase 2 and phase 3, and they're exciting and really targeting an area that is really, really critical, which is slowing down disease progression. If you're interested in any of these neuroprotective trials, we're doing all of them here at UF. So please feel free to reach to us to see if you're qualified for any of these trials. Most of them are looking at very early patients that are not taking medications yet, but some of the alpha-synuclein interventions are allowing patients that are taking medications to be part of it. Exercise is particularly interesting because if you think about it, the effect of exercise has been so powerful that we're now looking at moderate exercise as a drug. We're looking at it the same way that we will look at any other intervention. The effect of exercise is that powerful. And we're trying to measure that effect in a randomized control placebo study to determine what's the effect of exercise on slowing down Parkinson's disease. And then I'll stop there so we can answer some questions. Thank you so much for your attention.
Okay, so the first question that I have, and I have a list I've been keeping, is can I delay the onset of motor fluctuations by delaying the start of taking levodopa carbidopa? I have young onset Parkinson's, and so I'm trying to wait until my mid-50s to start.
If somebody that has young onset Parkinson's disease, we know that's a risk factor to have motor fluctuations. Can you delay the onset of it? Probably not. We know now that the most powerful determinant of motor fluctuation is disease duration, disease severity, and among with some of other factors that I mentioned. The biggest evidence we have about that is that there was a study recently published a few years ago that looked at two groups of people that started medications in Africa and people that started medication in Italy. In Africa, the only thing they have is levodopa. In Italy, they have all kinds of medications. So people were delaying the onset of levodopa with the hope that can we see less motor fluctuations as time goes by. And then when they follow these people in the two countries at 5 years later, what they found is that the occurrence of motor fluctuations was about the same between the two groups if you follow them long enough. So again, it seems like disease duration, disease severity are important factors to develop these motor fluctuations. Now, when you have young onset PD, it's a little more complicated than that because you're a higher risk. So I would definitely encourage to work closely with your doctor to figure out what's the best strategy for you. There are a couple more nuances to this, like the dose of levodopa may be critical. So we know that probably around, based on some of the post-hoc analysis on other studies, when you take more than 4 tablets a day, that's when the risk appears to be a little bit higher. Below that may not be as high. But again, if you're a female, if you're young, if you have young onset PD, things may be a little bit different. So that's when Parkinson's management becomes more of an art than a science.
Yes, I've heard that before. No, that's great advice. Okay, so the next question is, I have a long wait in the morning getting started. What do you suggest? Pills take an hour or so to get me moving, and my doctor just prescribed Xadago. What are your thoughts on this drug?
So it seems like by the report, it seems like what you're experiencing is early morning bradykinesia. You start your day really slow, and as I said before, sometimes as the disease changes over time, the medications take way too long to get your day started. So in those instances, some of the rapid-acting medications could be quite helpful. Like the injectable Apomorphine could be really good because it takes 10 to 15 minutes to kick in. Inbrija, the inhaler by mouth, may also have an effect. The difference between Inbrija and Apomorphine is that Inbrija comes in 2 doses, basically. Like the maximum dose that you can get is the equivalent of about 1.5 tablets of levodopa. So if 1.5 tablets of levodopa do not get you on, if that's not enough to control your symptoms, then the inhaler may not be the best option. And the Apomorphine sublingually or the injectable may be a little bit better. So the rapid-acting medications may be a better option for early morning slowness. Xadago or sulfonamide, I didn't cover it on the talk, but it's a MAO-B inhibitor, has been studied quite a bit here in the US. It prevents the breakdown of levodopa, just like any other MAO-B inhibitors. It's just affecting a different enzyme. And in studies have shown to increase on time by about an hour. So overall, it will increase the amount of levodopa throughout the day. It's a long-acting medication. You take it once a day. The effect may not be strong enough to really quickly and consistently improve the early morning slowness. So maybe a rapid-acting medication may be better for that probably in the morning. I think Xadago will be good for the rest of the day. And it's a very well-tolerated drug. It has been a little expensive to get it if it's not covered by insurance, but seems to be well tolerated and also reducing off time by about an hour.
I hope that helps you answer those questions that our participant asked. The next one is kind of similar to that, I think, in that it's asking can cause your mouth to be sore, and then the injectable obviously, you know, might hurt or feel like a little bee sting. And the questions related is could you alternate between the three?
There are different drugs. So apomorphine, subcutaneous injection, and the sublingual film, they're the same medication. Inbrija, it's a different drug because it's levodopa. And you can potentially alternate between them. You want to be consistent because you want to know what works. And depending on the severity of your symptoms, the Inbrija may not work consistently, as I mentioned before. It's probably, although you can combine them, probably once you find something that really works, it's probably best to be consistent and using that as opposed to trying to alternate. But I guess it's possible. I haven't suggested that. I'd probably try one. If that didn't work, move on to the next one. And if one medication is working, probably work on trying to minimize the side effects or the irritation caused by the injections.
That makes sense.
Dr. Ramirez Zamora, can I jump in on that? I know the question initially was regarding getting started early in the morning, and then you talked about the Inbrija as opposed to a pill and a half of carbidopa, levodopa.
Uh-huh.
The Inbrija, I believe, is 83 mg of levodopa, correct?
84. Uh-huh.
Wouldn't it, I mean, if you're talking comparative to the oral medication, the pill, doesn't that oftentimes get hung up in the gut, and that would delay where the Inbrija might have that immediate effect maybe until the pill kicks in, or can they be used in concert that way? Should the person take their medication and then go ahead and inhale Inbrija?
You can. You're supposed to, actually, Vince. Like you would take your pills and then you use the Inbrija as an extra inhaler. And what happens sometimes is that, let's say that the medications just happen to work really well that day, and then you ended up with a little too much dopamine and you're a little dyskinetic. And the next day they don't work that well, and you're just fine. And that's a line that you kind of have to make adjustments depending on that, but you certainly can. And the Inbrija is not supposed to be taken alone. One interesting thing that we saw in the clinical trial, when we did the clinical trial, is that people were able to use it up to 5 times a day, but the average number of usage was only 2 throughout the day. So I don't know if it's because of some of the side effects or because the medication didn't provide the benefit, or maybe it was the population that was enrolled in the study. I think that the cough is a concern. Like some people, get it and it's uncomfortable, but you can combine the 2 medications for sure.
With regard to the cough, and I would suspect that could be one of the reasons people don't like to take it as frequently, I would imagine. Is there any potential there for any other viral infection as a result of inhaling powder into your lungs, especially given that in the days of COVID, I mean, that would be the last thing you want to see. Is there any potential there?
In the clinical trial, I think there were 300 patients in that trial. The risk of upper respiratory infection was the same between Inbrija and placebo. So it at least is reassuring that early on doesn't seem to increase the risk of infection significantly. It was not statistically significant. I think it was 12% and 10%.
Next question is, and this is probably not going to be a quick answer, is does lack of dopamine cause the brain to shrink?
No, I think that thinking of the brain, like when we look at MRIs, and if you have ever heard your doctor say, well, there's a little shrinkage on your MRI, that it's a structural change at the level of the brain. Like the whole structure of the brain seems smaller. The lack of dopamine, it's a microscopic level. And that's why MRIs don't really help us to diagnose Parkinson's, because the lack of dopamine can only be seen at the microscopic level. The number of dopamine neurons in our brain, it's about 0.5% of the total neurons in our brain. Only
Wow.
half of a percentage are dopamine neurons. They're very unique. They're very peculiar. So if you remove those, that 0.5%, the overall structure of the brain will remain about the same. But that shrinkage, it's something that happens more related to aging, vascular changes. There's a bunch of other reasons as the disease progresses with Parkinson's. There may be some, it depends on how you measure it. But with regular MRIs, it's probably the contribution of dopamine loss is probably very, very, very small.
That makes sense. I never knew there were that small of a percentage of dopamine neurons in the brain. That's fascinating.
They're very unique. So they are tonically activated. They're always firing.
Yeah.
They're a pacemaker. They have a pacemaker. They're always firing a specific rhythm. They have unique calcium channels, and the arborization, the dendrites, are incredibly complex. Each neuron is estimated to have about 2 million connections of those dopamine neurons.
That's so cool.
They're just unique. They're just unique.
That leads us into our next question, which has to do with constant firing or electrical firing. And the question is, are there side effects from having DBS on all the time?
That's a great question. Really great question. We don't think so. However, it may be better not to have DBS all the time, but we don't know that yet. We know that depending on what part of the brain is being stimulated, the side effects can be easily reproducible, but it is possible that you need these rhythms or you're interrupting rhythms that are important for other function. We're just not measuring that, especially that becomes really hard as the disease continues to progress. In Parkinson's, as far as we know, we don't have any studies that are comparing DBS on and off and see there or adaptive DBS, these strategy that I mentioned before, where you turn off DBS when you don't need it, and then you turn it back on when your tremor is back. We just don't have a good answer about that. We suspect that it's probably better to have DBS only when you need it, but we haven't really established that when you have the DBS on all the time will cause any long-term side effects. And when you see side effects, you're able to manage them with DBS. You can make adjustments and limit that. And we have 30 years of experience with that. We have a brain bank of people that have DBS. So we have looked at the brain pathologically in over 130 cases. There's no significant inflammation, gliosis, scarring long-term. And when you look at the connections of the neurons, you see what you would expect in somebody with Parkinson's disease and not that different. So
wouldn't that be analogous to kind of like what you were saying about the dopamine neurons themselves? They're always firing. So with DBS constantly being on, would that not emulate some similarity?
Yeah, I think so. I think that it will be very close. That's how the brain is working. The reason why we're like trying to figure that part is that, you know, sometimes you wonder, like, well, are these rhythms that may be causing this problem, as we're suppressing them with electricity, are we suppressing other rhythms that may be useful for other functions? So far, we have found that the suppression of that abnormal firing with DBS has been positive in many domains. We haven't found something that it will make it negative. But we're trying to answer that question. Like, there's reports of STN, DBS helping with sleep, helping with constipation, with mood. There's all these very positive things that happen with DBS. But maybe, I guess the question is more specifically to, okay, maybe you're stimulating a little bit off, and everyone's brain is different. So maybe we need to identify what are the connections that we really want to stimulate with DBS beyond of what we can do clinically, and use advanced imaging or technology to help us to dictate, okay, this is what we want to see at the level of brain activity, or special advanced imaging to make sure that we get the benefit without any potential side effects. And that's where the field is going, I feel.
Yeah, lots of exciting things coming out in both neuromodulation, genetics, pharmaceuticals. So we have another question that leaves the brain for a bit, goes down to more of the gut area. So this question is, thank you, this was an excellent presentation. I heard that the appendix is linked to PD. Do you know if there is any truth to that?
Yeah, so there was,
We got you going everywhere today, Dr. Alt.
yeah, no, these are really great questions. Gosh, this is really thought-provoking questions. Uh, well, about a year ago, there was it made the news, this publication showing that people that have their appendix removed early in life have lower risk of having Parkinson's disease. So it posed the question, well, maybe if I have my appendix, that may have something to do with it. I don't think we know the whole story. I really think that we are just starting to understand the connections between the gut and the brain, which are very clear. We have more neurons in our guts than we have in our brains, and they're connected. So, like in the 70s, when people were doing, when we didn't have omeprazole or all these anti-reflux medications, what people used to do is just go and cut the vagus nerve at the level of the stomach to prevent acid reflux. So people that get that vagotomy have a lower risk of Parkinson's disease, suggesting like, okay, if Parkinson's starts somewhere in the gut, then maybe travels through the nerves into the brain. It seems like there must be an interaction between the gut inflammation, gut bacteria that triggers something happening, that abnormal protein accumulation in the gut. We got a grant from the Parkinson's Foundation to specifically look at that. So we're actually looking at the genes and as patients with Parkinson's and taking a small sample, small biopsy of the gut and looking at the amount of inflammation, look at the gut microbacteria and correlating that with the genes and the amount of accumulated protein in those samples. So we're really interested in trying to understand that connection much better, because if we can identify that connection at the genetic and inflammation level, we may have treatments that may slow down Parkinson's. Like if you treat hepatitis C with medications that reduce inflammation, or if you treat inflammatory bowel disease with medications that reduce inflammation, that seems to also reduce the risk of developing Parkinson's disease. Quite interesting.
Very interesting. Wow. We might have to have you back just to talk about that. And I can tell that Vince wants to end this, and I'm sure you do too. And I want to just end it with one last question. I really like the idea that you ended with, where you said, you know, exercise is like a drug, right? If we could prescribe it as a pill, everyone would take it. Do you think one day we'll kind of have an understanding of how exercise is sort of providing these neuroprotective things to the brain, and could we one day potentially have a pill for that?
I think so. I really do. I think the effects of exercise are non-specific. Right. I think that whatever that exercise is doing, it affects all the systems in our brain. That's why it's so powerful. So I don't think that we're going to have a pill that will reproduce the effect of exercise. But I think that we're going to have a better understanding of how exercise and the right kind, and how we may be able to personalize exercise treatments as we learn more about it. Yeah. So I think that eventually our prescription is going to be on the script. It's going to say this kind of exercise for this duration of minutes using this equipment 3 times a week or something like that.
I love it.
I think you hit the nail right on the head there as far as the exercise. And if you look at it in terms of even what we talked about with the DBS surgeries and some of the newer implements that are coming out, these are all tying right into personalized medicine, if you will. So why would not exercise, if we view it as a drug, be something that we would then prescribe personally and specific to that individual based on their own physiology and their own specific needs? I hate to say this, I don't want to let you go, Dr. Ramirez Zamora, but I do have a couple of quickies I have to ask you, so forgive me. One of them had to do with the subcutaneous levodopa therapy. There was 2 different companies you'd mentioned. I believe it was Neuroderm and AbbVie. Certainly, I think AbbVie, they're the makers of the Duopa pump. I'm wondering, what is the value difference there between this subcutaneous and this more GI invasive type of pump? Is there a huge difference, or is it a different application, again, for a different type of human being?
If the subcutaneous infusion shows to be maybe similar or as effective as the Duopa, nobody will go through the Duopa treatment anymore. Right. It will be abandoned, and then just concentrate on subcutaneous levodopa. Because Duopa is highly effective, but it comes with complications. Those tubes don't last too long. We have to change them quickly, or relatively regularly. They could be blocking, dislodging, cracks on the tooth, stomach issues. So if the subcutaneous is anywhere close to similar efficacy, we will only see subcutaneous levodopa.
I could see why AbbVie would be interested in that then, if that was to put their Duopa pump out of the ballpark.
Yeah, my guess is that they will continue to provide support to people that have Duopa, but then transition everything to subcutaneous.
Right. The other question was, and it's a little bit off the track a bit, but it was the KYNMOBIT, which the sublingual Apomorphine. Yeah. It seems to me back in late 2018, early 2019, that thing was hot to trot. And then all of a sudden it got back burnered. I just wonder, purely from a consumer perspective, how does something like that was so out there, so hot, and then got cold, and now it's back, but now it's in the mainstream? What do you know what happened there?
Yeah, the FDA required additional safety data. So when they submitted their application for approval, the drug was clearly effective. It was not a matter of efficacy. The FDA just wanted additional safety data, and it took a while for the company to put that together, submit it to the FDA, and another 6 months to get it approved.
I also heard that that sublingual film was pretty nasty tasting. Any truth to that, or do we not know? Do they improve that, or?
I heard a few people, but I heard also the people say that it was fine. I think they actually, the company knew about it, and they've been trying to improve that. So I'll right, yeah. Once we really get it out there and start using it, we'll be able to tell.
You know, today's program, I mean, this is so excellent. We'd love to have you come back in the future.
It's exciting times. There's I didn't mention it on the talk, but there's a couple of other. There was a new infusion that includes Stalevo in Switzerland. They got that approved. Levodopa was approved in Italy about 6 months ago. So it's an exciting time for treatments and PD. What we do need is to continue to put the word out there for anyone that has Parkinson's disease. We need to find ways to slow down disease progression. And to answer that important question, we really need the help of everyone in the community with Parkinson's to be able to participate in those trials, try to answer that question. So we really need everyone's help to be able to find something that's going to slow down disease progression. And if anyone is interested in any of these potential trials, please feel free to shoot me an email. I'll put my email in the chat. If you're interested, we'll be happy to see you here at UF.
Thank everybody for participating and all your great questions. We'll see you all again.
Thank you all so much. Thank you, doctor.
Thank you. Have a great day.